Good evening, everyone. Welcome and thank you for joining this 1-hour live education session, followed by a 15-minute Q&A on getting it right first time with MyoSure, a pathology perspective. My name is Rachel Williams. I am the Manager of Scientific Affairs for Hologic across EMEAC, which is Europe, Middle East, South Africa and Canada. I'm delighted to introduce you to our speakers this evening. We have, first of all, Mr. Francis Gardner, who's a consultant in gynecology and gynecological oncology at Queen Alexandra Hospital in Portsmouth. Francis will be presenting second on the benefits of MyoSure for directed biopsy and resection versus blind biopsy, and has a wealth of data which he will share with you this evening. We also have Charisse Hill, who's one of our 5 Hologic clinical application specialists in the UK. Charisse has a BSc in cellular and molecular medicine, so a keen interest in the topic this evening. And she'll be presenting first on the importance of obtaining high quality tissue samples. The agenda for today's session is looking at the issue of tissue, a quick look at the current UK NICE guidelines. We'll share some UK-specific data which has been presented at the BSG, ESG and a few clinical papers, then go on to the specific benefits of MyoSure, then hand over to Mr. Francis Gardner, who will take us through a clinician's perspective and, as I say, shares the wealth of data that he has collected and published. Then we'll follow with a 15-minute live Q&A. Training certificates will be provided for all attendees this evening, as you can see on the screen. It's important that if you have viewed this evening's session as a group, that you ensure we have all names. So if you're using one device, one laptop or iPad and sharing between colleagues, please ensure that we do have all the names. We only track the lead login name. So if you email us with an email I'll provide in a moment, and which hospital you're from, we can provide the certificate for all attendees. If you have any questions for our speakers this evening, you can write the questions in the following ways. If you're watching on a phone or iPad, then you need to tap the screen. You'll see 3 dots. Just click on the Q&A dot highlighted in the first picture here and type your question. If you are using a laptop, then you should be able to see the Q&A to the right of your panel, and you can type your message. We'll address all questions at the end. We will aim to answer all of them during the live sessions. If not, we need to get more data, we will come back to you following the webinar. So just to assure you, the Hologic team are all working and available to support our customers during this difficult time. If you do require one of us to visit the hospital to support cases or help with training, etc., and it's safe to do so, please let us know. We can also offer support via WebEx training or telephone support. So the email you can see on the screen now is specifically our UK Gynae Surgical team at hologic.com. And without further ado, let's begin. I'll hand over to Charisse.
Hello, good evening, everyone. So first of all, I'm going to talk about the importance of tissue collection. So proper tissue collection, the quantity and quality of the tissue that is received in the lab directly corresponds to the quantity and quality of the tissue that is available for the pathologist to assess. So we're looking for adequate specimen with intact tissue fragments and minimal artifact. This leads to an accurate diagnosis, so it directly correlates the final diagnosis and ultimately the treatment of the patient, which leads to an optimal treatment, avoiding over and under treatment, and reduces the need for repeat procedures. Mr. Gardner will speak about this later on. So one of the studies, which was by Kandel et al., I found particularly interesting because they spoke about clinical outcomes of patients with insufficient samples from endometrial biopsy or curettage. And you can see highlighted, there was an instance of insufficient samples and 78 patients went on to have a hysterectomy, but 51 of those patients, it was benign. So they went forward for a procedure that they didn't actually need. And interestingly, inside that paper, they stated that such samples were more commonly encountered in elderly patients than younger ones. Pathologists generally required one intact tissue fragment containing both glands and stroma for premenopausal patients, but 5 to 10 strips of atrophic endometrial epithelium for postmenopausal patients. So likely the patients that you are going to be seeing quite a lot of. So what is the challenge? We don't want any scant tissue. The MyoSure procedure is performed directly under visualization, so you can see exactly what you're taking. Just to give you a sort of visualization, you want to be looking at it almost as if it's a jigsaw puzzle. If you're given a piece that's just thrown all over the table, you've got to try and rearrange it to make some sense of it. If some pieces are already together or you've got a whole picture, you can see the image or ultimately what you're trying to find. So in terms of what is a good tissue specimen, you want to be able to see the architecture and the differentiation between glands and stroma. You want to look at the nucleic appearance, you want to see if there's any pleomorphism, and you want to see if there's presence of necrosis or other features of malignancy. As you can see in the bottom image, that is a non-intact tissue specimen, and it's really, really difficult to see the difference between the glands and stroma. So the challenges we face, you can have obscuring blood, so particularly in terms of propelling, it sometimes takes a lot of blood with it. You can just see, you can't really see much of the glands and stroma in this piece. With MyoSure, we have our Aqualex fluid management system, which flushes the sample, and you get really nice pieces of chopped tissue free from any blood. Thermal damage is also a problematic thing. With MyoSure, it's a mechanical device, so there's no thermal component. You have grouping of cells, as you can see here. I will try and highlight. This can lead to misinterpretation of diagnosis. Another thing that can happen, especially if you're scraping, so things with curetting, you can get something which is called telescoping. And what this refers to is you have glands within glands, and it can be misinterpreted as hyperplasia or carcinoma. So potentially your patient will be coming back to have another procedure done to confirm the diagnosis, or actually going forward for a procedure that they don't necessarily need. Crush artifact, so when you're scraping, you're going to disrupt the tissue. With MyoSure, because it's a cutting mechanism, you get those nice slices of tissue and you don't get any of those crush artifact. Mr. Gardner will speak on this a bit later. So the above image depicts endometrial cancer in an intact specimen. If the cancer was in fragments, it would be really, really difficult to try and diagnose. So what we kind of know from the Salim study is that complete extraction of polyps with curette is only 4%, and a complete extraction of a polyp using polyp forceps is around 41%, so relatively quite low. So the current guidelines from NICE was updated in March in 2020, and they state to offer outpatient hysteroscopy in women with heavy menstrual bleeding if their history suggests submucosal fibroids, polyps, or endometrial pathology. To ensure that hysteroscopy services are organised to enable progression to see and treat hysteroscopy in a single setting if feasible, and to obtain an endometrial sample only in the context of diagnostic hysteroscopy, and do not offer blind endometrial biopsy to women with heavy menstrual bleeding. So this is one of the UK studies that was for the BSG last year from Leicester, and it was outcomes of ambulatory hysteroscopy mechanical morcellation in a multi-ethnic population by Barney et al. So they had a cohort of 605 patients, which all had a Papel before they went forward for a MyoSure procedure. And as you can see, only 4.5% or 17 patients presented with complex hyperplasia with or without atypia and cancer. However, in the samples that were taken from the MyoSure, 24.2% or 90 patients, they found to have hyperplasia or cancer. So potentially those patients could have been missed. Another study that's worth noting, so the Greater Glasgow and Clyde did an audit. This is Stob Hill Hospital, and they did endometrial polypectomy using MyoSure morcellation in an office setting over a 23-month period. All procedures were performed in a one-stop outpatient setting, and all patients had confirmed endometrial polyp diagnosed at a previous hysteroscopy. Interestingly, what they found was 9 of these patients had endometrial biopsy reported as benign in the weeks leading up to their procedure using a PEL, and one patient had a benign result from a targeted polyp biopsy and was later found to have an endometrial carcinosarcoma after polyp morcellation using a MyoSure. So what we know about MyoSure is we've got lots of data on it, and we've got good 12-month outcomes. For fibroids, 96% of them are removed, and there's a 99% removal rate for polyps. And we've got really, really good patient satisfaction rates. So as I mentioned previously, we've got quite a good level of studies that date back to 2015. And as you can see, so one of them is from Leeds, and they found that 98.1% of the polyp was completely removed versus the polyp forceps and the curettage. So how can MyoSure help you? So we have several devices in our portfolio. We have the MyoSure manual, which can do directed biopsy and small polyps. We have the MyoSure Lite, which can do smaller and slightly larger polyps. We have the Reach, which can do polyps and small fibroids. And then we have the XL, which can do all of the aforementioned, as well as larger fibroids. So we can help facilitate a see and treat. So we have the MyoSure manual, which has an integrated suction. You literally just squeeze the handles and it will draw the tissue into the blade and cut. So it sucks and cuts at the same time. And at the back, you have a clear tissue trap, which is irrigated, and that's where your specimen will be collected. This is really good for your targeted biopsies. You don't need the fluid management system with this one either. We've also recently launched the Omni hysteroscope. So we take into account what people have to say in terms of feedback. We made the scope longer. It's also 3 scopes in one. So instead of having to switch out from a diagnostic scope into a MyoSure scope, you've got a 3.7 diagnostic sheath. You've got a 5.5 classic sheath, which can facilitate your light and reach devices and manual. And then you have the 6mm sheath, which is your XL. So the dilatation has come down, which makes it really, really good for an outpatient setting. So for anyone who doesn't currently use MyoSure and is potentially looking to get it set up pretty quickly, we have a thing called a fast start, which all you will need for that is a drip stand, your pressure cuff and giving set, your MyoSure manual, and one of our scopes, whether it be our classic scopes or our Omni hysteroscope. Similarly, if you're looking to set it up simply to start with and you want to switch to our automated devices, so your Light, Reach and XL, you can have your drip stand, pressure cuff and giving set, a tissue trap, which can be attached to a wall suction or a portable suction device with liners, your MyoSure controller and foot pedal, the handpiece, and obviously you will choose that depending on the pathology you see, and then the scope, whether it be the classic or the Omni. So just over to some case studies. So there was one patient with postmenopausal bleeding. The patient underwent a hysteroscopy. They saw that there were polyp-like areas inside. They removed all areas of interest and sampled the endometrium with the MyoSure device, and it revealed that the patient had a pathology of grade 1 endometrial adenocarcinoma, sorry. And then for the second case study, which is slightly more interesting, there was a 44-year-old lady with abnormal uterine bleeding. She underwent a hysteroscopy with a MyoSure and a blind sharp curette. The physician noted that the MyoSure system enabled easy visualization and removal of multiple polyps. The pathology from the MyoSure demonstrated a minute focus of endometrial endometrial adenocarcinoma and raised concern for Lynch syndrome. The blind curetting showed no overt abnormal pathology. So had this lady have only had just the curetting, she would have been missed, but the MyoSure picked up the adenocarcinoma. And the patient subsequently went forward to have more procedures done, and the grade 1 adenometrial adenocarcinoma was confirmed. So there was a LOFA paper in JMIG, and there's a nice quote from inside that, which was, hysteroscopy with directed hysteroscopic biopsies of small lesions and/or continuous suction curettage of whole uterine cavity has been shown to be more accurate than relying on blind tissue retrieval techniques. And I'm going to pass over to Mr. Gardner for his presentation. Thank you.
Hi, my name is Francis Gardner. I'm a gynaecologist and gynae-oncologist based in Portsmouth, and I also work in London. Now, I've had an interest in office-based procedures since, ironically, I worked in Leicester with Olivier Barnet. And my experience now goes back over 25 years of doing office-based procedures. So I've had a strong interest in this area of our service, and I've always looked to adopt and assess new technologies. I think Portsmouth, we are one of the first centres to adopt the MyoSure system in the UK. And I think we probably continue to be one of the major users of the device. So what I'd like to do is just talk to you about my sort of clinical aspects of why tissue biopsies are an important aspect. I'm just going to switch to my presentation. Super. So what I'd like to talk about is the benefits of the MyoSure for the directed biopsy and whether or not we should be doing resection or blind biopsies. I have to disclose that we have a research group in Portsmouth, and I'm the lead gynaecologist within this research group. And we've been very lucky as a hospital to be a reference centre for a number of companies, including Hologic. I've been a member very recently of the Hologic Advisory Board. I have been doing that for some years, and I continue to provide proctoring services for the use of the Hologic surgical products. And I have to say, I would not be proctoring a device that I didn't have full advocacy. So what are we going to discuss? So very similar to Cherie's, why is effective biopsy important? What constitutes a good biopsy? And the implications for inadequate specimen sampling from a clinical perspective, and how does the MyoSure aid a coherent and effective treatment diagnosis, and the UK clinical data and the impact of improved sample quality. So why is effective biopsy important? What we do know is that heavy menstrual bleeding has been a major impact on the quality of a woman's life. This was highlighted again in the NICE guidance on heavy menstrual bleeding. And we also know that endometrial pathology increases with age, particularly with postmenopausal status, and with the use of such drugs as tamoxifen. We also know that hormone replacement therapy, even as a combined preparation, increases the risk of endometrial pathology, and particularly of polyps. But what seems to be particularly relevant in our society is comorbidity, with increasing rates of obesity, diabetes, and hypertension. These all impact on the incidence of endometrial pathology. So the RCOG and the British Society of Gynae Endoscopy have come together with the Green Top guideline, and they've identified that it's really important that we get appropriate tissue sampling to rule out and identify endometrial pathology, particularly in these groups of women. But what's also of paramount importance is what's happened with COVID over recent months. COVID's had a very major impact on healthcare in the UK. Services across the board have been reduced or even suspended completely, both in primary care and in secondary care. We know that nationally, GP referrals for either suspected cancer or confirmed cancers has reduced by 60% in April this year. And Cancer Research UK have estimated that the impact of these changes on the services are that there's approximately 2.4 million people either waiting for screening for suspected cancer or investigation of confirmed cancers and treatment, which approximates around 4% of the national population, which is, in my mind, a shocking statistic. Furthermore, the impact of COVID is that patients are having difficulty accessing the services. And even once in the services, there are other hurdles. We now have COVID-free green pathways in most hospitals. And these pathways require self-isolation of not only the patient, but also their whole household for 14 days, which can pose significant challenges for many households. And COVID-19 testing has to be performed prior to any proposed surgery. And these changes have emphasized the need not only to offer one-stop see and treat services in the office or clinic setting, but it's so important to get the test right first time. And this will allow us to proceed more efficiently in the patient care pathways to make appropriate diagnoses so we can offer appropriate treatment. So what constitutes a good specimen? Well, for those of you that are starting new services, and for those of you who are moving services from inpatient to outpatient settings, it's very important, particularly if the services become busy, to have robust standard operating procedures. In all of our clinics in Portsmouth, we have established a WHO checklist, and this is critical in the identification of the patient to ensure that you have the correct patient sat in front of you so that we can link any potential specimens to that patient. It can have a catastrophic impact if a specimen is misidentified, and potentially patients can be misdiagnosed. So appropriate labeling is absolutely essential for a good specimen. When it actually comes to collecting the specimens must be put in an appropriate fixative. There are a number of fixatives that are available depending on the test that you're expecting, but for the majority of patients, formalin fixative is the appropriate fixative. However, it's important that the formalin is within date, as by the nature of these preparations, sometimes they're left in store cupboards and go out of date and lose their ability to fix the tissues. Once tissues are collected, it's important that they're not hanging around on a clinical surface, because that can allow desiccation, and this again can affect quality of the tissue that's relayed to the pathologist. And once the tissues have been labelled and collected, it's important that they are transferred in a timely fashion to the laboratory, because overfixation can again adversely affect the quality of the tissues. Now, what's also important is the actual tissue that you obtain. It's absolutely critical that the tissue that's presented to the pathologist is representative of the underlying pathology. And what we do know in pathologies such as polyps, there's often several histologies within an individual polyp, with areas of focal hyperplasia, potentially focal atypia, and potentially even invasive disease within a single polyp, which may have otherwise benign features. So there's a big discussion as to whether or not a polyp should be either sampled or removed, but I would counsel that polyps should always be resected completely, and particularly the base of the polyp should be resected, because there's often adverse histological pathologies in the actual base of the polyp. Furthermore, if you resect the base of the polyp as opposed to just taking the body of the polyp, that actually reduces the incidence of polyp recurrence. And it's also important to ensure that there's appropriate volume of tissue in any specimen that's collected, because if the histology has an unusual appearance, then the pathologist may need to perform additional procedures, such as immunohistochemistry. And thus, it's important that there's adequate tissue so that further sections can be cut in the laboratory and further staining techniques utilized to obtain a reliable diagnosis. I would also counsel regarding the actual method of collection of the biopsy, because it's important the appropriate technology is used. We know that energy devices using either electric cautery or heat can adversely affect the quality of the materials obtained. And it's also important to use a surgical blade to obtain the specimens, because crush injury can again alter the morphology of the tissue obtained and impair the ability to make a reliable diagnosis. Now, should we be doing blind biopsy? The simple answer is no. There's huge amounts of data, first, dating back for over a decade. I've quoted this paper here from 2008, where they found that sharp curettage, pipelle, and use of polyp forceps gave poor sensitivity in diagnosing pathology. There was incomplete sampling of the uterine cavity. There's insufficient material obtained for analysis, and regularly there's contamination of the specimens with blood and crush injuries and the telescoping artifacts. And what we also know is using blind techniques, there are very low rates of complete resections. So both NICE, the BSGE, the AAGL all recommend using direct visualization as the current standard. And blind techniques, although still widely used in the UK, is no longer recommended. In this meta-analysis that was published in 2016, over 1,000 postmenopausal women with abnormal uterine bleeding or postmenopausal bleeding were evaluated through 12 studies. And what was a consistent finding with other previous studies was that dilatation and curettage produced insufficient samples. Nearly a third of their specimens were insufficient for histological assessment. But what's most concerning from that study was that 7% of the specimens that had insufficient tissue on subsequent investigation were found to have endometrial cancer. And they concluded in 2016 that the sensitivity of endometrial sampling to detect endometrial cancer, and especially hyperplasia with atypia, was very much lower than previously thought. And as a result of that, more and more of our organizations, including NICE, are now recognizing that these blind procedures should not be performed. With visualization, use of resectoscope and VersaPoint, these technologies will allow you to direct biopsies, but unfortunately they use electrical energy and they require multiple manipulations of the uterus, so they don't tend to lend themselves very well to awake patient procedures. And we know that if you're using electrical energy, that there's a 1% risk of major complication with transmitted energy through the uterine wall, potentially causing visceral injury. And furthermore, the tissue that obtained from these technologies is very much inferior from a histological point of view. And So what is the impact of having an inadequate tissue sampling? The reality is it has huge implications for the cost effectiveness, the clinical effectiveness of the service, and the overall patient satisfaction. Patients who have inadequate tissue samples have the inconvenience of being brought back to the service, to have further investigation, to have further invasive investigations with further hysteroscopy, and particularly during COVID times, bringing patients back to the hospital potentially unnecessarily is not without risk. We know that the hospitals are concentrated centres for COVID, and each attendance has a risk, even though it may be minimised as much as possible. It also causes delay in care pathways, delayed diagnosis, and if not appropriately reinvestigated, misdiagnosis. And both of these issues can lead to adverse prognosis if there is an underlying cancer. An increased risk of breaches if a cancer is diagnosed because of late presentation in the cancer pathway. So why does the MyoSure aid a coherent and effective treatment and diagnosis? The MyoSure system was specifically designed for the purpose it's used for. It's not been adapted from a different technology. And the benefit of this is it supports its use in the awake patients in the office setting. There are very short treatment times. It's a very safe device with a low risk of uterine perforation, less than 1 in 1,000 cases. It gives you very superior visualization, and it requires just a single uterine manipulation, which lends its use to the clinic office in the awake patient. Treatment times, as I've said, can be very short. Once you become proficient in the resection of polyps with MyoSure, then most treatments can be completed literally within seconds, if not just 1 or 2 minutes. And even substantial fibroids up to 5 centimeters can be resected in less than 15 minutes. As I've said, the risk of complication is very low, particularly the risk of perforation is less than 1 in 1,000. And this is facilitated by having good visualization, and the actual cutting device has a blunt end, which means that inappropriate pressure on the uterine fundus will not lead to perforation. And the actual cutting window of the device is on the side, and this again reduces risk of inappropriate perforation. And because the device is normally used with a fluid management system, and so manipulating intrauterine pressure can tamponade any potential bleeding, then there's no requirement for either electric cautery or diathermy energy. And all tissues are removed through the device using a surgical cutting blade in the device. So there's no thermal injury either to the uterus or the resected tissue, and there's no crush injury to the specimen obtained. Because the tissue is extracted through the device, you don't have a cavity full of chipped tissue as you would, for example, with a resectoscope. And so the superior visualization actually speeds the process and also makes the process safer. And as I've indicated before, from a patient perspective, it's an excellent device because it only has a single uterine manipulation. And so this provides best possible comfort and the lower risk of perforation. There's been many studies with MyoSure that have demonstrated its superiority over traditional biopsy techniques such as curettage. I've presented just one example here from 2017, where it's very clear from that study, which was using hysterectomized specimens, where they did a like-for-like biopsy with MyoSure Light and curettage, and the specimens with the MyoSure Light was very superior to the specimens obtained with the curette. Now, as we've seen earlier this evening, there's a range of devices in the MyoSure family. The smallest device, the manual, is ideal for performing directed biopsies or resection of small polyps. And you can see that the majority of the family, so the manual, the light, and the reach, can all be used with a very small operative hysteroscope of 5.5 millimeters if you've invested in the newer Omniscope. But even the older traditional MyoSure hysteroscope is only 6.25 dilatation. So for the majority of patients, there's no need for any kind of cervical ripening agent or any significant forcible cervical dilatation. And even for fibroids over 2 centimeters up to 5 centimeters, the larger MyoSure XL, again with the latest Omniscope, is just 6 millimeter diameter, or with the traditional scope is 7.25. So compared with its competitors from, for example, Medtronic, where a 9 millimeter dilatation is required for fibroids, there's a very significant benefit with regards to patient comfort and patient safety in the office. Now, the MyoSure manual, as previously indicated, is excellent if you're performing a diagnostic hysteroscopy and you find a small isolated polyp, or if you have a small isolated area of suspicious endometrium. And the benefit of this device is its very rapid setup time to go from the diagnostic to an operative procedure, because the device, as it previously indicated, has its own inherent suction, and you just require some fluid for uterine cavity distension to allow the device to be utilized. And it's got a very nice feature in that the specimen that you obtained is actually collected on the end of the instrument in the clear collection container at the end. So you can actually visualize how much tissue you're going to be presenting to the pathologist. And you can continue to take biopsies until you're confident you're going to have a reliable specimen. And as I've indicated, with the newer Omni hysteroscope, the dilatations are all very minimal, with a maximum dilatation of only 6 millimeters. And by using a single hysteroscope with a number of different sheaths, then you can traverse from diagnostic to operative procedures very swiftly and slickly. So the MyoSure hysteroscopic resection, in my opinion, and in the opinion of many, many other people now, is very nicely designed for the clinic or office-based treatment. It is a relatively expensive disposable device, but if you perform a business case analysis, it's actually cost effective because it averts many costs associated with traditional techniques, particularly the cost of inpatient admission, the cost of having an anaesthetic team if you're using sedation or general anaesthesia. And it's actually very much safer for these patients to be performed in an awake setting, as the risk of perforation is very much reduced. And also there's no risks relating to anaesthetic, which is particularly important in the comorbid population. And overall, moving these treatments and assessments into the office leads to huge improvement in patient satisfaction and feedback. And so overall, the hysteroscopic resection will lend itself to a one-stop see and treat service, which has been recommended by NICE since 2018. Now, from a UK data, there's limited data from the UK. Cherise has already presented some of the data, so I'm just going to present our own data from Portsmouth for your review. We published an audit in 2014 of 100 consecutive patients treated with the MyoSure in an office see and treat clinic. 63 of the patients were treated with the MyoSure Lite, and that included treatment of patients with either multiple polyps or large polyps. At that time, the Reach hadn't been released onto the market, and the MyoSure Classic was only available. And again, we utilized that to treat multiple polyps up to 6 centimeters and fibroids as well, up to 2 centimeters. And we also had patients that were treated with the XL with fibroids of up to 6 centimeters. And I have to note that the license is only to 5 centimeters. But overall, we found that in our audit, all of the patients that came to the service had 100% of their intrauterine pathologies completely resected and efficiently biopsied, and the histopathologist was able to perform an appropriate assessment of all tissues, identifying cases of both hyperplasia and malignancy. And you can see from an example of the types of cases that submucous fibroids such as this one can be completely resected with a very good view right the way back into the myometrium. And in that audit, we identified that normally we would have expected within polyps to have endometrioid adenocarcinoma in around about 1 to 2% of polyps. But by resecting the whole of the polyp and also resecting the base of where the polyp stood on the endometrial cavity, we actually identified 8% of endometrioid adenocarcinomas within those polyps. So, this again reflects the efficiency of this device in removing tissue and enabling the histopathologist to make a reliable assessment. We've also done a further study within our own department, which we presented at the ESG last year, where we looked at 458 consecutive PEL samples that were taken in clinics that were not ambulatory clinics. And what we found in those PEL samples, in the premenopausal women that you would expect to get a reliable sample because the endometrium tends to be thicker and more functional, that despite these features, still nearly 12% of PEL biopsies were insufficient for histological assessment. And what was very interesting was that 40% of biopsies that were deemed sufficient due to ongoing symptoms and ongoing concerns still required further biopsy. And that 3.8% of those repeat biopsies, even when they are performed as an inpatient with curettage, were still insufficient. In the postmenopausal women, of which there are 129, as expected, virtually double the number of PEL biopsies were insufficient, and a similar number of the sufficient biopsies required further biopsy. And what was again of concern was that 21% of repeat biopsies that were performed with curettage were again insufficient. However, those patients that were referred to an ambulatory clinic and were offered a MyoSure diagnostic biopsy, 100% of the repeat biopsies performed were sufficient for histological assessment. And this demonstrates that even in those patients that were probably more challenging due to uterine distortion or difficulties accessing the cavities, the MyoSure was clearly very effective. And this is an example of one of the patients that we identified within this group. This patient was a 52-year-old. She was not postmenopausal, but she had perimenopausal bleeding. and she had a clear risk factor for endometrial pathology with a BMI of 61.3. The consultant that performed the hysteroscopy documented a suspicious abnormal endometrium and performed a Papel endometrial biopsy. And unfortunately, you can see from the screen, the majority of this specimen is just blood, with very, very few fragments of endometrial tissue. As a result of the concern relating to this patient returned to my clinic, and I performed a repeat hysteroscopy, and I documented that this patient had a characteristic change within the endometrium of endometrial cancer. And the MyoSure directed biopsy confirmed the presence of a grade 2 to 3, so high grade endometrioid adenocarcinoma of the endometrium. And this demonstrates a clear example of where a patient's care has been delayed. The turnaround time on average is 10 working days for a biopsy to be histologically assessed and reported. And so that's effectively 2 weeks before we were even aware that the initial biopsy was insufficient for assessment. There was further delay in this individual patient for her to then come back to my hysteroscopy clinic, and I then had to take a further biopsy with a further 10-day delay in getting the second biopsy result, and which then led to a referral to the MDT. And ultimately, this patient had a total laparoscopic hysterectomy under my care. But this patient unnecessarily breached her cancer targets because of the inherent delays that occurred due to the insufficient biopsy. So the MyoSure hysteroscopic resection, it gives superior quality of tissue for histological assessment. It very significantly reduces insufficient sampling. In our hands, in my unit, the MyoSure gives 100% of sufficient specimens for histological assessment. And it certainly reduces the need for repeat assessments compared to both blind curettage and Papel endometrial sampling. So I would counsel you that despite the additional disposable costs of these devices, because the number of patients that are requiring further investigation and further biopsy, it in fact is cost effective to use these devices for directed biopsy. It's certainly clinically effective, and it's certainly safer than blind biopsy than traditional inpatient resections. So that's the end of my presentation, and I think we'd like to move on to the Q&A session.
Yes, thank you, Francis. We've had a few questions. One of the questions I'll address straight away. One of the clinicians joined late. We have recorded the session, so it will be emailed out on a flyer, the same as you joined this evening live. You will be able to see that on demand. And the UK team have done a number of training webinars as well as addressing MyoSure and setup. So they will email all of them. So you will see that in a few days when we've put that together. One of the first questions, Francis, I think you have covered it in some aspects. It's how do you justify the cost or make the business case to move from Papel biopsy to bringing in MyoSure manual or light, I guess, to the trust, and what would be your advice, having already made that case in your own unit?
So the first part of developing a business case is to identify the size of the actual problem that they have. And what we've demonstrated was that even in premenopausal women, around 12% of patients required repeat biopsy. And in the postmenopausal patients, over 20% of patients required repeat biopsy. And when you factor in the additional costs associated with bringing patients back, there's the administrative charges of sending further appointments, which, depending on your processes and your trust, can be between £25 and £75 just to create an appointment. You've got the additional cost of repeat histology. The average cost of histological assessment of a endometrial biopsy in the UK is between £75 and £85 if it's just simple histological assessment. You've got the additional costs of bringing the patient back to clinic and utilisation of a slot within the clinic, which could otherwise have been used for another new patient. And if you build that broader picture, and particularly if you're avoiding bringing patients into the operating theatre session, actually the sums add up very, very clearly in favour of getting it right first time, doing an effective biopsy, and, you know, if necessary, and I would counsel it is necessary, to use the more expensive disposable device.
Okay, and following on from that, in PMB, do you select which women you will do MyoSure in comparison to Pipelle? I think you've answered that already. Do you use endometrial thickness as a guide, as in our unit, the majority of women with an endometrial 4 to 8 millimeters, we tend to find a normal cavity at hysteroscopy?
So what we do know is that there's a very clear correlation between endometrial thickness and pathology. Traditionally, we used a cutoff of 5 millimeters as to whether or not we would proceed to perform a hysteroscopic assessment. In England, that's now come down on various recommendations to 4 millimeters. And in some centres, they're now using 3 millimeters as a cutoff. But what's very important is that although hysteroscopy is a very good way of investigating the endometrial cavity, there's been a number of studies, such as the study published by Rahimi, I think it was in 2014, where patients who had negative hysteroscopies, they still had a significant number of patients who had hyperplastic changes and hyperplastic changes with atypia. And so it's really important that we do take biopsies, even in patients who have an apparently normal looking endometrial cavity. You know, within our own department, we had a patient who had a normal hysteroscopy, who subsequently had an endometrial cancer. At that time, we were not using MyoSure. It was pre-2012, and you know, that patient did have a Pipelle sample, and the Pipelle sample was benign. But less than 3 months later, the patient presented with endometrial cancer with a very heavy postmenopausal bleed. And the reason that I can remember this case very well was I was clinical director at the time, and we had to put this patient through a serious untoward incident process of evaluation. So, you know, we know that there are cases where there's significant endometrial pathology, which may be microscopic and not particularly visible. You know, all cancers start at some point in a very small place. And, you know, we need to acknowledge that. If a patient has abnormal symptoms, that's a red flag, and I would take a biopsy, and it needs to be a good biopsy, an effective biopsy.
Okay, related to that question, you might have covered it because I'm reading the questions at the same time. What is your experience on asymptomatic endometrial thickening in a postmenopausal woman? Do you scope or treat, and how many of these women in your experience have abnormal histology?
So if the patient has a patent endocervical canal, the likelihood of an endometrial pathology is very low. The danger is if the patient has complete stenosis, whether it's related to previous colposcopy treatment, sometimes just in the postmenopausal state, the endocervix can be completely stenosed, sometimes relating to various prolapse procedures such as Manchester repairs, the cervix can be completely stenosed. So if there is an endometrial thickening, particularly if it's over 5 millimeters, I will offer this patient an office-based awake diagnostic hysteroscopy. And what we do know is those patients that have a stenosis, then the incidence of a significant endometrial pathology is very much higher than those that have a patent endocervical canal. So, I would offer the patient a hysteroscopic assessment.
Okay, two similar questions. So I'll start with the first one. Any tips for introducing the scope through the cervix to reduce the risk of pain and failed instrumentation? Also, what analgesia or local anesthesia do you use, please?
So in premenopausal women, the overwhelming majority, we can do a saline hysteroscopy. There's no need for dilatation, and you can simply pass the hysteroscope through the cervix with any major issues. If the patient is feeling significant discomfort, then we can always stop and we can put in an intracervical block. I personally use Lignospan, which is 2% local anesthetic with adrenaline. But the majority of premenopausal women, there's no need for any local anesthetic. There's no need for any manipulation of the cervix directly, and vaginoscopic approach is entirely appropriate. In the postmenopausal women, we start vaginoscopically, but if the cervical os is very tight or stenosed, then we usually stop. We place a speculum, we put in an intracervical block, and then we can either do a hydrodilatation using a tenaculum with countertraction, or if that's not possible, using a disposable dilator. All patients that come to our assessment clinics are asked to take paracetamol and ibuprofen prior to coming to the clinic 1 hour before. If the patient's particularly anxious, then we may, and they're not driving, then we may also add in some tramadol when they come to the clinic as well. But actual oral pain relief is actually very minimal. And I think if you've got a good hysteroscopic technique, then the overwhelming majority of these procedures can be performed in an awake patient. And as soon as the patient starts to feel some discomfort, I think it's important not to persist, and that to pause, pass the speculum, put local anesthetic into the cervix, and then proceed painlessly thereafter.
Okay, there was an additional question on the same topic. Do you encounter the difficulty with myoscope entry due to tight endocervical os at the outpatient clinic, and how would you solve that to avoid going to a GA hysteroscopy?
So if I'm using a traditional MyoSure scope, that's 6.25 millimeters in diameter, then the majority of those patients, particularly in the postmenopausal age group, will require dilatation. And so in that situation, I'll put in an intracervical block, and then in most cases we can hydrodilate through, but sometimes we do have to still use a dilator.
Okay, and related to that, how many patients on average don't tolerate the procedure in outpatients in your experience, and then are referred on to theatre for GA?
So that's a really, really important and interesting question. It's very much operator dependent. I do a regular clinic, which you know is very busy clinic, with up to 10 or 12 patients in an afternoon. And in 2019, I referred 2 patients to theatre for procedures. And both of those women were women that had some psychological issues. Well, they're actually mental health issues, not psychological issues. And I didn't feel it was appropriate to be performing an awake patient procedure on those women. But using vaginoscopy, it's possible to do hysteroscopic assessment even in people that have not been sexually active. I think that, like I say, it's very much operator dependent. In our department, we have some individuals that will refer up to 30% of their patients for inpatient treatment. And I think it's all about technique, frankly.
Okay, and then back to analgesia and anesthesia. Why do you need an adrenaline contained LA? We only use LA without adrenaline.
Yeah, over the years, we've been running our ambulatory service in Portsmouth as a comprehensive service since around 2009. And we've trialed various analgesic regimes. And what we found, we've tried Cytonest, which has mifepristone. No, not mifepristone. It escapes me. It's local anesthetic plus another drug. And we tried lignospan, and we've tried plain local anesthetic. And what we found was that plain local anesthetic was associated with a higher chance of vasovagal attack. And I suspect that the adrenaline will reduce peripheral vasodilatation and maintain blood pressure and reduce vasovagal. So, yeah, we did an internal audit within the department of the different local anaesthetics. This ban was best tolerated.
Okay, another question. In the absence of a localized pathology, do you use MyoSure to biopsy the whole endometrium?
In a postmenopausal woman, yes. In a premenopausal woman, we tend to do selective biopsies because, particularly if there's fertility requirement, we wouldn't want to perform excessive biopsies, which could potentially cause harm.
Okay, now, Francis, in scientific affairs, I sometimes get questions, and every now and again I get the same question. Over the last 2 weeks, I have been asked about morcellators, and I think there is some confusion with laparoscopic morcellators and the FDA and AAGL warning sometimes being confused with tissue morcellators. I have answered it to the best of my ability, but I really value your opinion on the risk of cancer spread using MyoSure or similar tissue removal devices, please.
So that you'll note from my slides, I've actually moved away from calling the MyoSure system a morcellating device. The reality is it's actually surgical resection. There is a surgical blade within the device, and we're cutting away chips of tissue which are being removed through the system. A morcellator tends to effectively grind up the tissue, completely fragmenting it, and and you know, that will be associated with inherent differences. Now, what we do know is that there was anxiety about saline hysteroscopy when that was introduced in the 1990s. Traditionally, hysteroscopy was performed with CO2. And the anxiety was that cancer cells particularly could be spread by flow of the saline through the fallopian tube into the peritoneal cavity. Now, what we do know is that concern has not been borne out over several decades now of experience of using saline as a medium. And we also know that because the MyoSure device actually draws any tissue that's resected through the device, then again, the risks of having malignant tissue potentially flowing up the fallopian tube again is very much minimized. And so, overall, I don't think there is any significant risk, particularly with the sort of normal type endometrial cancers. Certainly with sarcoma, the mode of spread tends to be hematological. And so again, there is no logical reason why, using a hysteroscopic resector or morcellator would increase the risks of or adversely affect prognosis if you're using it for diagnostic purposes. And we've certainly been using the MyoSure very, very extensively within our department for 8 years now. And we've certainly not seen any adverse effects of its use. And we treat around 150 endometrial cancers a year. And we've not seen any change since the change in technologies. Does that help?
It does, yes. Thank you very much. So I'd like to thank you especially for sharing your own data and taking the time in this busy evening. I know you've had a busy clinic this afternoon as well. It's extremely valuable for Hologic to work with physicians to see the data that comes out of the units. As Francis said, we do very frequent advisory boards, and what I've learned in the device world, my world was pharmaceuticals before now, is that we really do listen to physicians and tips for how we should develop things. The REACH and the MyoSure manual were both developed following advisory boards, so that we really knew what our customers needed, and also we are gearing up far more towards an outpatient or ambulatory setting, which, as you've reiterated, will become more and more important in the situation we find ourselves in with COVID, which is not going away anytime soon. We also have a very active diagnostics division that are very busy on COVID testing. So I'd like to thank you this evening for spending all of that time and answering very many questions. Thank you all the participants for spending some time with us. As I said at the beginning, it is being recorded, so you will be able to go back over the slides and hear the speeches again. Just to remind you, in case you missed the start of the presentation, I know a couple of people did. If you did view as a group, please ensure we have all of the names so we can send you your certificate of attendance. And if you've got any further questions we haven't managed to answer or have come up, once you've thought about this for a little while, please email us at ukgynesurgicals@hologic.com, and between us, the team and I will do our best to answer those. If you would like any further information on our products, NovaSure, MyoSure, Aqualex, Omniscope, please also look at our website. We have a number of resources, some physician testimonials, some great videos and animations. So that's at gynesurgicalsolutions.com, where you'll find a wealth of information on our resources. without further ado, thank you to our two presenters, Cherise Hill and Mr. Francis Gardner. We really appreciate the time you've spent, and thank you for joining us this evening.